Good afternoon and welcome. I'm Gina Adams with Wareologie. We're going to pause a little bit while people join us, but I am so excited to be here today with Jennifer Reft, Doctor of Physical Therapy, and to have people join. If you would like to, in the comments on the right-hand side, we'd love to know where you're joining from today. And like I said, I'm just going to wait a few minutes while people join us and we'll jump right in. So I'm going to moderate the comments here. And so let's begin. So my name is Gina Adams, and I am the founder and CEO of Wareologie. Today, I just wanted to thank you for your time and joining myself and Jennifer Reft, our Doctor of Physical Therapy and expert in residence for Wareologie. We want to just spend a bit maybe giving you the background of how we came to develop portable parallel bars on wheels. And I'd like to, of course, introduce Jennifer, and she can begin her presentation that was originally delivered at the American Congress for Rehabilitative Medicine this past November. The title of her symposia is Using Tools in a New Way, Portable Parallel Bars in the ICU. Welcome, Jennifer. How are you?
Hi, Gina. I'm great.
Great. So for those of you who may not be familiar with Wareologie, we are a product development company that develops products to help restore levels of independence and empower people to age in place. We launched in 2019, and we take a unique user experience design approach where we partner with our end users to collaborate and develop products that meet the demands of our users. We are so fortunate to have been contracted by the Veterans Health Administration in 2021 to develop a portable parallel bar device that folds and has wheels so that we can deliver them directly to the patient's bedside. Today, I, again, kind of checking the comments to see where everybody's from and who's chiming in today, but I wanted to give you a background of Jennifer Reft. As I mentioned, she's a doctor of physical therapy, and Jennifer comes to us with over 20 years experience working in a wide range of therapy practices, including inpatient, acute care, ICU, day rehab, as well as outpatient in-home health physical therapy. Jennifer has presented at combined sections and is published in peer-reviewed journals. She taught at the higher ed PTA program at Morton Community College for over 13 years and also served as an academic clinical coordinator for 2. We are proud to have Jennifer on our team. And today, just a little background, we're going to present, we'll do a demonstration, and then we'll have some time for Q&A afterwards to answer your questions. But please feel free to comment, and I will be moderating that as we go. So thank you so much, Jennifer. She's going to present today on her findings and the opportunities to advance patient access and improve patient metric outcomes. Thank you, Jennifer.
Thanks, Gina. So like Gina said, this was a talk that I gave, a little bit shorter version of what we gave at the conference, and kind of looking at some new ways that we could advance care in the ICU. So objectives, I'm going to review a little bit from 2 qualitative studies about the ICU experience from the patient perspective, review a bit about the barriers and limitations to mobilization, what we know about current mobilization practice, and kind of how important it is that we mobilize the patient not just for physical purposes, but really to encourage recovery of the whole person. And I think one of the many things that came out of COVID was how really traumatic the ICU experience can be, because we had so many people in the ICU and so many people in acute care for such long periods of time. I think some more thought has been given to how can we not just allow people to survive the experience, but really thrive and really be prepared to take that next step? So Coroner et al., this was a study done in a qualitative study of about 15 patients, different diagnoses, different lengths of stay. Some of them were very short, some of them were a couple of months. And everything that's in qualitative study, usual caveats that it's a relatively small group of people, but certainly things that were presented here track with what we know from quantitative studies. That patients experience memory loss, hallucinations, and delusions. And he kind of described one of the things they describe is kind of this noxious cycle where people are tired and they feel weak. So it's difficult to engage them in any kind of any kind of therapy process because they kind of don't feel like it. So it's kind of a bit of a challenge to get them involved because we know that mobilization can actually make them feel better. And that can help decrease kind of the irritation and the discomfort if we can get them moving and kind of more normalize things. But it can be kind of hard to get people to that place. One of the things they emphasize in this study is this concept of recalibration of self, and that the patient has this, this prior version of themselves. They have this current version of themselves, which is quite different. If you think about being in the ICU, it's sort of like being in space, right? It's a very different type of place. And they have this future self that they want to get to. And there's this that people are, like I said, weakness is a big thing. People are shocked. One of the things that what came out, people's discussion of this, that they just couldn't believe how weak they were, that they couldn't walk. And so there's this real gap in their perception of themselves from what they visualize, that pre-ICU self to this current self. And so this recalibration process that they describe in the study can really help be moved forward with mobilization, so that because our core selves are so in line with what we're able to do, physically, when we're not able to do anything, that really kind of messes with that view. So the idea is that, with mobilization, with get people moving, that can help kind of move them to that future self. The other thing they talk a lot a bit about is recognizing milestones and goal setting. So we all know as therapists that one of the important roles we have is to remind patients where they've come and where they are now. That's something that you have to do regularly, really throughout the spectrum. It's particularly important, and though in the ICU setting, because of that memory loss, right? Because there's going to be gaps. They're not, it's hard for them to kind of orientate themselves because it is such an unusual environment. So we play an important role to help people recognize where they've come and where they're going. The other important thing is goal setting. So we know that, patient-centered care and patient-centered goals has become a bigger issue in the past couple of years. And anybody who's worked at any level of inpatient care, I certainly know this is my experience. Getting patients to set goals sometimes in that setting is a little bit of a challenge because, if you ask them what their goal is, a lot of times it's, I want to get out of the hospital, and we really want them thinking further beyond that. And that's an important role I think we as therapists play, that we want them to start thinking about what is life going to look like when you're out of here. Again, coming back to that idea of recalibration. And one of the comments in the coroner study is that most patients felt, as I said, a little bit thrown by that. They were like, well, can you just tell me what to do? But the authors emphasize that with a little bit of push, patients could identify because that's really what our goal is, not for people just to be able to walk, but to be successful. Um, so this is again another study. This is a different study. It was done in Sweden. It was part of a larger study looking at our interventional study, looking at different breathing techniques. These were patients that were not necessarily ICU patients, but they were all post-abdominal surgery and part of an early mobilization program. And a lot in this study tracked with what was in the coroner study. That they didn't describe a noxious study, but people had a hard time sort of getting themselves going. But they reported that, yeah, they felt better. One person even said, even vomiting was better sitting up than lying down. And one of the things that they discuss in this study, which they also bring out in the coroner study, is this idea of being confident in their caregivers, and having confidence, being prepared, that they appreciate that the people that they're the healthcare providers that they interact with try to prepare them for everything that happens, and support them, and they have really faith and trust in them, and that's a really important part of the process. So this is a study that was done in China, and I think it had about 500 people. And just to comment on how the really significant, cognitive issues that come after ICU, and they noticed that mobilization, early active mobilization, was associated with decreases in those cognitive losses. So barriers and limitations. So patient-related barriers. I'm too sick, and they are. To be fair, they are in the ICU, right? So it's kind of our job to educate them and the staff to educate them. Why actually movement is good for them. Things like respiratory instability, fatigue, refusal, monitoring. That kind of goes back to that noxious cycle where it's kind of hard to get people out of that idea of you really will feel better if you just can push it a little bit. Barriers and limitations, cultural barriers. So a lot of times the ICU staff doesn't kind of value the mobilization, or doesn't kind of buying in with that. And so that can be a challenge, right? If you're coming against staff, maybe that doesn't have that kind of experience or background. So often, when you're seeing somebody in ICU, you check the chart, but then you're always going to talk to the nurse, right? And nurses vary in terms of their comfort level sometimes with mobilization. And so if you have somebody, and this is no knock on nurses, but just doesn't have that in their background, sometimes they can be a lot more cautious and a lot more restrictive on what they allow their patients to do. And that comes back to kind of a lack of knowledge sometimes. And then patients and families. So we all know that when people are in the ICU, in acute care, families are really key. Sometimes we feel like we're treating families as much as we are the patients. And it's important to educate them as well. And sometimes the families are kind of in a better headspace, right, to hear it. But we really need their buy-in and their support. And that's something that we can play a large role in. So kind of structural barriers, so limited staff. So again, going back to staff and their experience, that often people, if they haven't experienced in this area of getting people up, they might be a little more cautious. Lack of protocols. So often if you have a situation where, it can be helpful to have kind of standing protocols for certain types of patients. So then there's kind of less back and forth of whether it's okay or not okay to get this person up. And then limited equipment, right? So here's where we come in, that when you have people in ICU, when you have people that must be seen bedside, especially who are pretty weak, there's a particular set of demands that have to be met right there and then. And often if you don't have the right tools, it can be difficult to get people up the way that we want them to. So what are current mobilization practices? So we know that we can do supine activities. One study showed that really only FES increased muscle mass, and it's debatable how applicable that is. ADLs, and of course ADLs are important. It's worth noting though, like in Corner, that he kind of noted how the authors noted that wasn't really seen as real rehabilitation. That's just the stuff that you do. And then there's standing activities, more formal mobilization activities, with a walker or specialized equipment. So some of the more specialized equipment that's out there, there's a lot that's been added in the past 10 years or so, are some of the more sophisticated beds that can they're sort of like very sophisticated tilt tables, right? As well as harness systems. And those systems are certainly important for certain types of patients, but they are more involved. They're not intuitive, right? Harness systems are a fair amount of time to set up. And they're not, ideally you want something that anybody could get the patient up with, that's relatively easy to set up, that's relatively intuitive, that everybody feels safe and confident with, right? That can be pulled together very quickly. That would be your ideal tool. Why am I emphasizing the importance of getting people up, right? So we know that I would say in the past, at this point, 20 years, one kind of active discussion, at least in neurological physical therapy, and I think in a lot of areas of therapy, is, are we really working our patients enough? We know that you need to, if you want to drive recovery, you need to kind of work people kind of, I don't want to say to their limits, but we want to make sure we get them kind of in that zone, so to speak. And we know that kind of supine activities and things like that do not to not go very far in that regard. And we also know how important task-specific training is. That is, if you want to help people to stand up, if you want people to walk, what do you have to do? You have to stand up and you have to walk. So I think getting people on their feet, and we know that, I know that's my personal philosophy, you know, when I'm working in the hospital, even at home health sometimes, is getting people on their feet as long as possible, because we know that's the functional position that they have to work in, that we want to make improvements in. And if we don't have them on their feet, it's very difficult to kind of manage that. So we know we can get the greatest level of intensity in task-specific training for people who are upright, you know, ideally staying on their own feet and feeling supportive and confident. This is where we come in with the parallel bars. So I will say that I've always been somewhat biased towards parallel bars. I feel that, you know, especially having a lot of experience in with neuro patients, that it's difficult with a walker to properly stand. If you know that the person's going to need a fair amount of assist, or maybe you're not sure, it's difficult to manage a walker and a patient at the same time, you know, especially if they've got other issues going on. So with parallel bars, obviously, you can have the patient hold on to the bars, but more importantly, you as a therapist can properly position yourself in front of them, and you can really stabilize them at the hips, at the knees. You can really be sure of yourself that you can really control them in a way that you can't really with a walker. So I think for those first, you know, and the first time that you get somebody up from the bed, you know, it's a guess a lot of times how much help that they'll need. Sometimes you can kind of tell, okay, I can kind of guess they're going to need a lot because they're pretty big or they're not moving very much. Sometimes, you know, if they get up pretty easily, it's like, okay, this probably shouldn't be too bad. But you don't really know until you stand up. And so getting back to that idea of preparing patients and being confident, you know, for us, we need to demonstrate that confidence. And sometimes, you know, when you're working bedside and you're not sure with what you're dealing with, it can be difficult to kind of, I think, radiate that confidence with certain types of patients. So, you know, I think the genius of portable parallel bars is that you can roll these right up to the bed and you can have them stand up right from the bed. It's a very secure place. It's, as Gina will demonstrate, these pretty much go up and down in just a couple of minutes. So it's, you can spend honestly as much time um, with a walker. If you're trying to adjust a walker appropriately, you can probably adjust our bars a lot faster and get them up and down a lot faster. So it's very easy. And then once they are ambulatory, once they're past the point where you know, they can walk, then you can still do, I would say, more aggressive bedside therapy, you know, with standing activities and balance activities, early stair training in the steps, that I just think is just extremely difficult to manage with the walker. Our goal should be to get people on their feet as much as possible. And I really think in these early stages, something like, you know, having parallel bars right there is just super helpful, as well as increasing, you know, safety and confidence with the patient. So we know that early mobilization is safe and feasible. And we know that if we can get that intensity, get that dosage, get people on their feet. Because one of the things with the parallel bars is that this doesn't have to be PT specific, right? OTs could get them up, nursing could get them up. They're very easy to manage. And I think in a way, some of the other more sophisticated tools are not really. And we know that this weight bearing is going to promote kind of optimal dosage. These are some references. If anybody wants to have a copy of the talk, I'm happy to send it to them. And now I think Gina is going to take over and actually demonstrate use of the bars.
Thank you so much, Jennifer. That was amazing. And it's really great to hear perspective from you, the clinician. As I mentioned, I'm Gina Adams, and we're a product developer. And so one of the first tasks that we were required to do is to ensure that the patient felt safe and confident. We know many of the patients are recovering from falls, of course. So with that, I have the parallel bars right here. I'll talk a little bit louder. I'm going to put this down. But we are using a aerospace aluminum. So these weigh less than 60 pounds. If you're familiar with stand-up paddle boards, we did add a handle here so that you can lift these up and get them over, you know, steps and curbs and things of that nature. They have swivel wheels so that they can fit into really tight spaces, including elevators, around beds, and even in hatchbacks of cars. The swivel wheels come in and out very easily so that you can have this nice and durable during the transportation mode. And the entire device is adjustable for both pediatric as well as serving larger adults. All of the pins are attached so that there's no chance of losing or leaving something behind. And the, sorry. We also added outriggers here at the bottom so that you have nice vertical stability. And the floor has a patented anti-grip, anti-slip coating so that your patients feel safe, but also it doesn't move on the surfaces of the floor either. And I probably have these. And one of the other real added values that we haven't really mentioned are the space savings. Constantly are being complimented on the fact that in rehabilitation rooms that have very limited space, these can roll up and be stored in a storage closet as well. So there is that really nice interdisciplinary use to the tool. Don't know, does anybody have any immediate questions? The weight capacity is over 600 pounds, so it can withstand both the weight of your patient as well as the clinician standing on it. And the, just trying to think if there's any other questions out there. We're happy to answer. We are an FDA Class 1 registered company. We're manufacturing here in our home state of Michigan, so we're extremely proud of that. We are a Michigan certified company, and you can reach out to us at Hello Wareologie, and we spell it WAREOLOGIE, which represents independence and empowerment. So it is now 12:38, and oh, thank you for putting that up for everybody. We'd like to be able to reach out to you. Actually, I don't know if I can see the comments. Oh no, here we go. I'll switch over there. Oh yeah, thank you, Cynthia. So the surface is non-skid. That is correct. And like I said, it's patented from our manufacturer. So we're very excited about that. The device itself weighs just under 57 pounds. And the interior width is 26 inches. So it does fit a manual wheelchair, but not a power wheelchair. So if you wanted to wheel your patient up onto the platform and then have them stand up, you can do that. The next question is, what is the weight capacity and inside width of the device? So I'm just going to double check that for you to make sure that we have it, but the inner width is 26 inches. And the device itself is 5 feet long, 60 inches long, and that includes the ramps. There's one other question. Nope, I don't see any other questions. So if you would like us to reach out to you, please add your comments or your contact information in the comments so we can have that. And if there's any other, lingering questions, we are, again, now delivering I will tell you the retail price of our parallel bars are $5,500. And we are just really excited as we are going to launch our pilot with the Veterans Health Administration. We're working with the Hunter Home McGuire VHA in Richmond, Virginia. And so we're just so excited to be moving in and helping patients access physical therapy sooner and safer. Thank you, everybody, for coming today. I will hold out for a little bit longer in case some other questions come in, but I really want to thank you for your time. And do we have a government contract yet? Yes, we do. We have a couple. Yes. So Thank you so much, Cynthia, for your questions. And like I said, I'm Gina Adams, happy to answer any other follow-up questions. If you want to leave your information, we can reach out to you guys directly, but appreciate your time, and we look forward to helping not only improve your patient metrics, but also help with clinician efficiencies and staffing, because now we believe that people can treat patients more independently and not, hopefully lighten up some of your staffing demands. So thank you, everybody, and have a great day.